Andy. Can you see the screen? I just shared my screen.
Yeah, sure.
And can you see my video?
Yeah, definitely.
Okay, and hope I'm audible too. Okay,
Yeah,
okay. So, good evening, one and all. Thank you so much for attending this session. And I'm told we have a lot of doctors who had attended the module one, which was about cupping therapy. And I hope all have been practicing well. I'm getting good feedbacks. A lot of doctors personally commenting about the effect that cupping has already got into their practice. So, uh, trigger point therapy is very much essential, and from now on, we started doing cupping. Somebody messaged saying he can't hear. Am I audible?
yeah, it's audible. I think it's Dr. Vishnu's issue. I will connect to it. Okay, you can continue, doctor.
Okay. So, let's start with the topic. So today we're going to talk about trigger point therapy. I'm sure a lot of doctors, this is something that is new. This is something of the new age where a lot of sports people who are involved are actually, you know, getting more and more involved in this. And then you have the sports research council, a lot of people who are actually, practicing all this. So, as Ayurvedic doctors, it's very essential we understand what trigger point is, and I have been trying to share this knowledge for the past 3 years through various workshops. But since the last 1 year, I have not been able. The last workshop I conducted was in 2020 in January, and because of the COVID scene, we could not do it. And since this was an uh, offline class, and this is the first time we are going online. And so I welcome you all to the session. Let's go to the topic. And just we begin with a small prayer. Om Sahana Vavatu, Sahana Bhunaktu, Sahaviryam Karavavahe, Tejasvinavadidamastu Ma Vidvishavahe. May God protect us both. May He nourish us together. May we work together with great energy. May our studying be effective. May there be no hate among us. Om Shanti Shanti Shanti. And like all sessions, I would like to give my pranams to my ancestors. This is my great grandfather, Sri Talapalli Krishnan Vaidyar. He founded the tradition in our family, and I'm always indebted to him because he left a very big clue, in my life for me to explore. This is an year of a gentleman who's about 85-year-old. He's in our village. He's a very senior person, and it was about 3 years back he came to me for back pain, and that was the first time that I was having a doctor-patient relationship with him. And and he was telling me this when he was about 5 years old. He had come to my great grandfather for a severe or an acute colic pain, and my great grandfather did Agni Karma, on his ear, and you can see this was a mark, and and that was really interesting to me because we've never heard such things in practice. Yes, Agni Karma we do for lateral epicondylis tennis elbows, we do for plantar fasciitis, all those conditions, but we never have heard about doing Agni Karma on the ear for something related to the stomach. So it just gives me more and more encouragement, gives me more inspiration to explore different type of systems. Just be open to any methods, any new systems, and that's why I've been able to really and learn and adapt a lot of systems in my practice. This is my grandfather. He was also a very famous physician in his time. A lot of doctors came and visited, stayed in a house, and it was like a Gurukula system. This was my grandfather's brother, Sri Dr. T.K. Oni. He was an MBBS doctor. After his basic study in Ayurveda, he went on to do his MBBS, and he retired as a district medical officer, and he was the first one to do vasectomy surgery in my family. So I mean, in my whole district. So a lot of legends in the family, and this is something I every case I take, I always seek their blessings, and I believe that they are with me. So what got me thinking? Like every Ayurvedic practitioner, when we go out of college, mainly our intention would be, to start a clinic, to start a treatment center, to start, like a very, very basic, like a normal clinic. Those who have the, what do you say, the backup, they can really invest. But this is what everyone usually begin with, a small clinic where they can do small therapies, like probably start with an OPD, and then slowly based on the practice, slightly start building an IPD. So and like anybody else, even what I did was I used to hire therapists from outside, because giving salary to therapists was not really that feasible in the beginning of your practice. So what we do is we would hire people from outside. So there was a very famous family nearby, which is called Chototodil family, about 10 kilometers from my place, and they are very famous Vaidyas, and all the generations of their family, they were good masseurs, or like they were more into massage therapies. They were doing ortho cases, they were doing rehabilitation, and they were very famous in these different types of massages, etc. They were more into massages, not like how prescriptions and things like that. So two of them, Mr. Joshi and Mr. Jain, they came to me, and I used to hire them, and it was really interesting that when they came and when they were started doing treatments, my small treatment room, like my panchakarma room, was like a torture chamber. You'd hear my patients crying out loud, because they used to do it very deep and very hard, and things like that. But I realized that slowly after 3 or 4 days of into the treatment, the patients were not really complaining about the pain. In fact, they started feeling a lot better. And what I realized is that slowly, when when these people, I started getting more patients, so I started uh, giving job. I started having permanent therapists, like instead of these people, because they are my on-call therapists, and obviously we have to give more money to them. So I hired people, as therapists, and they were the ones who learned recently from colleges, or like these therapy courses. But when they were doing treatments, I was not getting the same results. So, and I realized that when they were doing massages, like Mr. Joshi and Mr. Jain, when they were doing massages, the effect would last longer. That I would have seen patients won't come back to me for another like 1.5 years, and and this was their effect. And this actually got me thinking, because in colleges we are taught that we have to do very mild massage. We just taught the 7 basic steps, and you close your that's general practice, where you close your fingers together, and then you do it in a stroke, in a smooth manner. And I've realized that many doctors who do massages by themselves, only those people try and innovate and do deep tissue massage and things like that. So uh, that actually gave me, and they would actually teach me like how there are these specific points in the bodies which are very tender, that initially when you press it, it's severe pain, and when you press it again, and then later you can see how it comes down. So History of trigger points. Therapeutic touch has emerged in all cultures and ages. Massaging painful muscular spots occurred in ancient Egypt, India, Japan, Korea, Rome, Greece, and Mesopotamia. So all these age-old, systems or these civilizations, they had these what do you say, evidence-based practices, right? Somebody who's interested in a body would become like a healer or a massage therapist. They would have got, they would have acquired the knowledge from a guru, and then they would do these specific kind of massages for specific kind of conditions, and it's been there since a long time. In the West, Goers, later Kellegren, Gunn, Travel, and Simmons all rationalized these hyperirritable spots as trigger points. So this was how the study of trigger points evolved. There is a very famous book called Travel and Simmons. It's available, I think, online. uh, they did the first study, and it was them which gave these spots. They named it as trigger points. So this is a graphic taken from an Egyptian tomb, and you can see there are people sitting there, doing massages, or doing some sort of therapy using hand. So if somebody does an acupressure, they would say this is them doing an acupressure, whereas somebody like an Ayurvedic doctor will say this is them doing some kind of pariksha, or these are paricharikas doing some kind of treatments. So trigger points in ancient world, and there are a lot of images that are found in ancient India, Japan, Korea, and Thailand. And most famous book, including massage, is the Yellow Emperor. It was the a famous book which is mentioned a lot in different types of massages, and it is the basic foundation of Chinese medicine, the Yellow Emperor. And the first references to tender trigger points in Chinese medicine were around 722 to 481 BC, when shiatsu was described in order to treat ashe and painful knots on joints. Shiatsu massage, is a very type of massage. It's a vigorous type of massage. You can just Google. You can just go to YouTube. You can see different kind of videos on shiatsu massages. And here's a very interesting word that has become, universal. It is called ashe points. Ashe points. AHSHA. Ashe points are nothing but painful knots and points. So, just to get a basic thing what it is, I want everyone to keep your hand on this shoulder area, right, just below this neck area, and try and feel for it. And when you feel for it, you can actually feel a small lump. Are you able to see it? Is it painful? Can somebody unmute and tell me if you can see it? At least a couple of people. Since all the cameras are off, I can't see anyone doing it, but I'm sure you can just unmute, anyone?
Yes, sir.
Yes, sir.
Okay, thank you. So, and this is a very, very important point, right? You know, and people come to you with pain, and they come and describe, I get this pain like this. Oh, doctor, I always have this pain. I always have this pain. It's always like this. The presentation of the case, and patients are very specific about the exact point where it is paining. And sometimes as doctors, in my initial days of practice, I would be like, just looking at them, and I'll be like, they would say, they got a pain like this on the back pain. I would say, okay, katigraha, let's go for rasna sattva kashayam, let's go for gandharvasta kashaya. All these things, this is what comes. If there is amatva, then go for ramahara, like amradotra kashaya, and this is what usually comes. And there was not a practice of actually going and touching and finding out. And later, it's when I started doing trigger points, I realized that when patients come and present their complaints, it is very essential that the doctor understands it, because when somebody comes with the pain like this, and I know exactly what they're talking about, so I go ask them to sit down, Then I try to palpate, which is like more like a sparsana pariksha, and I try to find out the exact point, and I try to analyze what that pain is due to. And when you do that, what happens is the patient is confident. The patient, the first thing he tells is, okay, this doctor, he knows or he has actually found out there's something wrong on the exact spot that I've been trying to say. And no matter which modern doctor you go to, nobody, cares to touches your body, even if it's an ortho, they would just look into it, oh, pain, X-ray, MRI, blood test, that's it. And people are like, and they just give you medicines or painkillers, injections, and what happens is, it's just temporary relief. And musculoskeletal conditions, I believe that painkillers are just not very useful in treating musculoskeletal conditions. You need to do something on the spot. You need to do something on that area. You need to identify the connections. You need to understand what it is. You need to do some hands-on treatments, and that's why uh, osteopathy, chiropractors is gaining huge popularity in the West. Sports osteopath is something that is on very high demand because in sports clubs and all these famous football clubs, they need a recovery, and they need a coach or they need a therapist, like a recovery therapist who help the patients to recover even faster. And all these people basically apply the theory of trigger points, and then go on and improve and try to come out with new theories, etc. So we'll see what exactly trigger point is in the coming sessions as well. So today we will complete the basic definition and understand what a trigger point is. So that's the idea. That's what we're going to do today. So trigger point, by definition, is a highly irritable localized spot of exquisite tenderness in a nodule in a palpable taut band of a skeletal muscle. So what it means is, it is localized spot, and it is slightly tender, right? And it is in a nodule. And if you can just appreciate it, you can find that there are like it is in a thick band. So what happens is you have the muscle fibers, they form a thick band, and the trigger point is formed there. It is best appreciated in your calf muscle. You can just go to see if you can press on the gastrocnemius, and you can see that there is a small, uh, hard, tender, you can find like a string that is there in the gastrocnemius muscle. So once you start practicing, you find it in a lot of places. So the name trigger point was coined by Dr. Janet Travel and David Simmons. Like I said, Travel and Simmons is a very good book that you should all go through, to understand more about musculoskeletal conditions and pain. In the West, Hippocrates wrote that physician must be experienced in many things, but assuredly in rubbing. So, which means, we should understand the body. Even in Ayurveda, we talk about darshana, sparshana, and prasna. By darshana, we understand the structure, we understand the posture, and in Sparshna, we try to analyze what is the main issue, we try to understand what is the pathology, and then we go and treat it. And then, of course, you have the Prashna, you understand due to what reason, this is, the habits of these people, etc. So, modern holistic medicine, Andrew Taylor still is considered as the founder of osteopathy. And a very famous quote from him is, a knowledge of anatomy is only a dead weight if we do not know how to apply that knowledge with successful skill. It is so true, because the first time I saw this proverb, I was quotation, I was like, this is so true, because we study anatomy in first year, and after that we really do not, uh, bother too much about remembering the particular anatomy. We are focusing more on the the nidana or the chikitsa aspect of it, not the very basic anatomy. We really don't apply that much. And the fascia is the place to look for the cause of disease and the place to consult and begin the action of remedies in all diseases. So another new structure, once you, this is how you should go. Once you understand what a trigger point is, you try to practice trigger point therapy, you identify these trigger points, you do some release, and then the next structure that you should look for or you should be thorough with is the fascia. Those who have attended cupping, I'm sure you remember the anatomy trains that I had just mentioned. Now you will get today you will get an idea how to connect it. That's the basic idea. So uh, this is a very interesting picture. This is about Andrew Taylor Still himself. He is actually lying down, and you can see that his rope, and you can see a blanket, right? And there's a story. He says that when he was about 10-year old, he used to get headache, and he made a swing from his father's plow line because his father was a hammer. Sorry, his father was a farmer, and when he made a sling, he could not lie down properly. So what he did was he used to tie a rope and just leave it about 8 to 10 inches off the ground, and then he would put a blanket on it and then rest his head, and he would just lie down. And whenever he had this headache, he used to keep repeating it, and he clearly says that I became easy and went to sleep, got up in a little while with headache all gone. As I knew nothing of anatomy, I took no thought of how a rope could stop headache and the sick stomach which accompanied it. So he says every time he used to have these headaches, his stomach was sick. After that discovery, I roped my neck whenever I felt those spells coming on. I followed that treatment for 20 years before the wedge of reason reached my brain. I could see that I had suspended the action of the great occipital nerves and given harmony to the flow of the arterial blood to and through the veins, and ease was the effect as the reader can see. So, uh, every time he used to get this headache, he used to lie down like this, and then and he used to feel relaxed, and also even his stomach would be all right. So later, when he learned about osteopathy, sorry, when he learned about anatomy, he realized that he had suspended the action of the great occipital nerves and given harmony to the flow of the arterial blood. So this is also a very common practice in nowadays. Whenever we get headache, we just tie a rope, or sorry, a cloth or a towel. Just tie it very strong, and then people feel a lot better or relaxed. Whenever they have a headache. This is a photograph of John F. Kennedy, the president, the ex-president of America, and this is Dr. Janet Travel. And when John F. Kennedy, President John F. Kennedy was, when he was very small, he nearly died of scarlet fever at 2 years, whooping cough at 5 years, digestive problem at 14 years, hypothyroidism at 17 years, and after a spinal accident at 30 years, he was almost completely bedridden. And not many doctors could really help him out, and it was Dr. Janet Travel who actually helped him out when he was very young. And on the right hand side, on the right hand side, you can see this is what is called as a pain map. So what it says is, for every specific muscle, there is a pain map associated with it. So that is the brilliance of trigger point therapy. We will understand more about it in the coming sessions. And just to give you an introduction, what is myofascia? Fascia in general is a covering, and myofascia is the dense, tough tissue which surrounds and covers all your muscles and bones. It also helps transport and move chemical and other substances around the body. Myofascia connects many of the areas of the body together, hence also called as connective tissue. So, what happens? The fascia is generally a covering, and myofascia is a covering. So, the myofascia it connects one bone or to a muscle, one muscle to another muscle, and there is and this is what it gives the term a connective tissue, right? So again, that term is coming up from now on. Every time you go online, you go to YouTube, I think all these terminologies should come into your head, like trigger points, myofascia, fascia, all these things, pain map, all these things should be keep coming to your brain. So, in just a basic thing about the fascia, in a healthy state, fascia is always relaxed and soft, ability to stretch and move without restriction. Fascia helps to maintain good posture, range of motion, and flexibility. It also gives our bodies tremendous strength and helps us to deal with stress and injuries. And when anything is affected with the fascia, loses its pliability, can become tight, restricted, and a source of tension throughout and the rest of the body. If trauma such as a fall, whiplash surgery, or habitual poor posture has a cumulative effect over time. So, if you can just focus and pay attention to this particular sentence, it says if there is a trauma such as a fall, like whiplash, surgery, or habitual poor posture, it has a cumulative effect over time, which means that some people they would have fallen down, they would have injured, they would have had fractured, some part, and it is later on, in later stages in life that actually they started having problems because that particular fascia is affected or restricted or there is adhesions formed, and then there is a lot of build up or cumulative effect over the time. And I don't know if you've noticed that when you do massages and when you actually do a deep tissue massage, people come and tell you that, oh yes, doctor, about 10 years back I had a fall and this thing hurt and I'm surprised it is still there. Patients remember those incidences, and that is the effect of and we should understand that body it has that what is a we can see such effects in the body if it is not taken care of. So we need to understand the concept of fascia. It has to be, and you need to keep doing a lot of reading about it. It is very important in practice, especially if you're doing musculoskeletal conditions. And we talked about fascia, we talked about muscles. So the myofascial trigger points, it is called, and why it is important that we should learn. MTPs are present everywhere and affects as much as 85% of the population in some time in their life, right? And it is present in babies and children. The impact of myofascial pain on health can be severe as patients not only suffer from pain and loss of function, but also from impaired mood, decreased quality of life. And like it says in a Shastra, there is no the definition of swasta. Prasanna Indriya Mana. So when people are in pain, there won't be any prasanna atma indriya mana, right? because they're always in pain and they're not getting any any results if they go to any doctors, and they feel they come to you. The exact words that I hear from patient is, doctor, all my investigation reports are normal, but I cannot get up from my bed. You go to the blood parameters, they're normal. Blood routine, everything is normal. There is no ESR, there is no uric acid, there is no suggestion of ASO, there is no RA factor, but still people come and say like, I have severe pain, and this is what happens. And when you understand this concept of trigger points, and that's when it will strike, oh, there is an inflammation in the fascia, and and when you think in those lines, you get a lot of answer to these kind of situations, right? Anyone who touches the body should have a thorough and deep knowledge of trigger points. It is a must, because like I said, I asked you to touch your own body here, and how many actually knew that there was something stiff or something hard in your back? Two doctors actually responded when I asked if they saw it. Can you tell me if you have that issue earlier, or is it the first time that you realized you have something there when you touched it?
I used to get when I get stressed or I sit for a long time, and when I massage that area, it subsides.
Okay. So what did you name it? What did you think it was so long?
I
Since you
thought
already...
it's some kind of we tell in Malayalam neerkettu.
Okay. Perfect.
Inflammatory. Yeah.
Yes. Perfect. And that's exactly, you get a lot of answers to all those things. That's a very vague thing in Malayalam. Neerkettu, it literally means like an inflammation. And what is neerkettu? That is a question that we doctors keep asking ourselves, or you keep, it is there, but you really can't understand it. You don't understand the structures exactly what is involved. So, and you will get that answer only if you understand trigger points and myofascia, pain syndrome, etc. So the concept of fascia and trigger points is something, and you are going to get your answer for that question. So it'll be easy for us to explain to patients as well. And perfect. So again, doctors here, I would like to ask you, what do you see from this? This was not my patient, but somebody else shared this picture. So I would like to ask you, what exactly is the, when you see a case like this, what goes into your mind as Ayurvedic doctors? Just give me any vague answers. There's no wrong and right. A person comes to you, a patient comes like this and presents himself. What will you do? What is your questions be, or what will go into your mind?
This is the case of kyphosis.
Okay. And as Ayurvedic doctors, since you said it's kyphosis, perfect. So what would be your treatment?
By the manipulation therapy, we can set it up to some extent in its original position. Manipulation.
Manipulation is in. Are you talking about like some kind of chiropractors or something like that?
Yes.
Okay. Yeah. So that's okay. Now, since you know a little bit of manipulation, I would like to ask somebody who's never done all that. Like never been doing manipulations or something. Like just the very basic. Like just say like how you pass out of Ayurvedic college, like. Or me 10 years back, right out of college, I'd be looking into this. I'd be like, Vata Vyadhi, Madhyama Roga Marga. Let's see, let's talk about Rukshana, Snehana, Swedana, Vasti. This is what comes into our, right? Am I correct?
Yes.
Yes. So what I'm trying to find out, do we actually? Okay, we'll just discuss about that. So just hold on to this picture in your mind. We'll come back to this picture after a few slides. Okay. Maybe not in this session, but maybe next session. We need to just remember this this photo. Okay. Next, this is a video of a patient. You can just mute. Okay, so this is my patient, and he's speaking in Malayalam. The words or what he speaks is not really relevant, but please watch his action. That's the whole idea I wanted to give. He says it starts from his neck, goes from the back of the shoulder, radiates to his arm, to forearm, and then coming down to the chest. He's being very specific. I'll just play that video once more. Just try to. This is like a normal patient, See, he's explaining his symptoms. It's like he gets pain initially here, and then he goes to the back, and then when it increases, it slowly radiates to his arm. He's getting neuritis in the tip of his fingers. And he says when he gets pain, he cannot even move his hands. So I hope it was clear. Those who understand Malayalam, it will be a lot easier. But those who do not understand Malayalam, is there any doubt with what the presenting condition is? I'm sure you've had similar cases in your. Was it clear? Did you understand the presentation or the presenting symptoms? Is it common?
Yes, sir.
Yes. Okay.
Yes.
I'm sorry to say this, but it is very tough taking an online class because all I can see is this screen and I can see a small window where I'm speaking. So I don't know how many doctors are present. So that's why I try to make it interactive. So please try to participate. It'll be a good thing for us as well. It's not easy. It's quite tough. When you just sit and a lot of. So I just want you to understand. This is what it is about. So again, as Ayurvedic doctors, we understand. Okay, so it's radiating, pain, Vata Vyadhi, and then you have your already set prescriptions in your mind. You give all that, and it's more of medicines, right? So just hold on to this video as well. So we have that picture and this video in our mind. So let's do a basic refresher on our anatomy and physiology, right? So very important to understand what trigger point is. So you can just see this picture. I'm sure we have, all seen this in our, in our UG. I think this drawing is a must in your anatomy record book, and I'm sure most of us have done it. So just to refresh it, the very basic unit of a muscle are these, the filaments, the actin and myosin filaments. Just refresher, there is a video where you can clearly understand, just trying to get those names back to our minds, as a refresher. And the actin and myosin, they combine to form the myofibrils. Myofibrils combine to form the muscle fiber, and the muscle fiber, it combines to form the fascicles, and these are the fascicles, and the fascicles combine to form the belly of the muscle, right? So you can understand that it is bundles and bundles and bundles of muscle. So it starts with the basic actin and myosin filaments here. It forms a myofibril. Myofibril combines as a muscle fiber. Muscle fiber combines as a fascicle, and the fascicle combines to form a belly of the muscle. So, and very interestingly, what you should understand that the muscle fiber, you can see the covering that is there in all these layers, right? The first covering in the muscle fiber is your known as the endomysium, right? The covering of the fascicle is called as the perimysium, and the covering of the belly of the muscle is called the epimysium, and the epimysium is continuous with the periosteum, right? So this is a very, very important structure that when we do a cadaver dissection, we just cut it off, right? We just cut and remove the layers of the fascia. We just say this is a fascia. We just cut and remove. We are more focused on the origin and insertion, or the nerve, or the artery, or the vein that is present there, because that's what we all try to identify when we do a dissection, right? But in a live human body, the structure that plays the most important function in your entire body is your fascia, right? And sometimes, and fascia is only what we learn in about what, less than 10 to 15 minutes in your 5.5 year curriculum. And whereas right, you come off to college, come out of college into your practice, and fascia is the most thing that you actually see, and the involvement of fascia so much. So for me, after I've studied so much, I study every day about fascia, and still, there is so much to learn. And I believe Ayurvedic doctors should definitely know what a fascia is. Otherwise, it is very difficult to understand many of the concepts that is there mentioned in our Shastra. So please do a refresher. I'll be sharing a video right now. We'll give you a small, quick, refresher on your anatomy and your physiology. So again, a small thing on your physiology, right? Here is a nerve. I'll just go back to that. Okay. So I'll just say, it's again the physiology of a muscle fiber, right? Physiology is you have a nerve impulse arriving at an end plate. You have the acetylcholine receptors at the choline diffusing into the synaptic cleft, and then you have the actin and myosin filaments, sliding over each other, and this is what leads to the contraction of a muscle, right? There is a very good video which is very easy to learn and understand. I'll be sharing it. I'll be showing it now, and I'll also be sharing it in the group, so you can. It's a YouTube video, so we can share it in the group as well. So the basic three types of muscles are the smooth, cardiac, and the skeletal. The smooth muscle is for your, the visceral organs, the cardiac for the heart, and the skeletal for the entire, the rest of the body. And the sliding filament model, and how these skeletal muscles are made up of bundles of protein fibers, actin and myosin filaments, and how the calcium and ATP causes the binding and unbinding. So here is a video. Please watch it.
You will recall from our early lessons on tissues that you're kept alive and moving by three types of muscle tissue: smooth, cardiac, and skeletal. Your smooth muscle tissue is found in the walls of all your hollow visceral organs like your stomach and airways and blood vessels, where it involuntarily and very usefully pushes fluid and other material around by contracting and relaxing over and over. Your heart is so important that it gets its very own muscle tissue type, cardiac muscle, which looks striped or striated. It also functions involuntarily to keep your blood pumping without you having to think about it. So when you hear the word muscle, you're probably thinking of the kind that you see on Chris Evans when he first walks out of that machine in Captain America. And those types, the ones you can see and feel and flex, are your 640 skeletal muscles. They're striated like cardiac muscle tissue, but they're also mostly voluntary, meaning you have to think about using them and activate them with your somatic nervous system. Most of them attach to your skeleton and create movement by pulling bones in different directions as they contract. Each one of your different skeletal muscles, like your biceps brachii or vastus lateralis or gluteus maximus.
Doctor, were you able to view the video?
Yeah.
Okay.
Muscles like your biceps brachii or vastus lateralis or gluteus maximus is technically its own organ made up mostly of muscle tissue, but also of connective tissue, blood vessels, and nerve fibers. And because your muscles are voracious energy hogs, each one is rigged up with its own personal nerve to stimulate contraction and its own artery and vein to keep it well fed with all the blood and oxygen and nutrients it needs to operate. So to understand those operations, we first need to get a grip on the anatomy of a skeletal muscle, which involves fibers within fibers and lots of layers. Basically, a skeletal muscle is constructed like a really sturdy piece of rope. Thousands of tiny parallel threads called myofibrils squish together to form muscle fibers, which are your actual muscle cells, cells with mitochondria, multiple nuclei, and a cellular membrane called a sarcolemma. Those muscle fibers then form larger string-like bundles called fascicles, which combine to form the larger rope-like muscle organ like your biceps brachii. Overall, this bundles configuration makes muscle tissue fairly sturdy, but considering how much abuse your muscles take when you do something like pretty simple, like lift a big bag of dog food, it's no surprise need a little help. That's why every muscle contains a few different kinds of supportive sheaths of connective tissue, the protective reinforcements to keep that bulging muscle from bursting. So that is the structure part of the story. But if you want to get into the nitty-gritty, the down and dirty of how you actually move, there are rules. Really just two main rules, and they have to do with proteins. And they're both true for a lot of the proteins we talk about, whether they're enzymes or ion channels or receptors or muscle proteins. And these rules are: 1, proteins like to change shape when stuff binds to them. And 2, changing shapes can allow proteins to bind or unbind with other stuff. So keep those rules in mind while we see how a muscle fiber contracts and relaxes. Now, remember those tiny myofibrils that bundle up to form your muscle fibers? They're divided lengthwise into segments called sarcomeres, which contain 2 even tinier strands of protein, 2 different kinds of myofilaments called actin and myosin. It's their angsty story of star-crossed love that fuels every movement your body could possibly dream of. A sarcomere contains both thin filaments, made up mostly of 2 light and twisty actin strands, and thick filaments composed of thicker, lumpy-looking myosin strands. Each sarcomere is separated by what's known as a Z line at either end, which is just a border formed by alternating thin filaments in a kind of zigzag pattern. A muscle contracting is all about sarcomeres contracting, bringing those Z lines closer together. All right, so now comes the romance. When your muscle cells are at rest, your actin and myosin strands don't touch, but they really want to. Specifically, that club-headed myosin wants to get all up close and personal with the actin. When this happens, and it will eventually, it's called the sliding filament model of muscle contraction. But in the meantime, like any good love story, there have some obstacles to overcome. Namely, actin is blocked by a couple of protein bodyguards called tropomyosin and troponin, which keep getting in the way. Luckily, these guards can be bought off with a little ATP and some calcium. I'd prefer cash and nachos, whatever. Remember, ATP is kind of like molecular currency. It contains chemical energy, and your muscles are all about converting chemical energy to motion, so they're always hungry for more ATP. Your muscle cells have lots of nuclei, but some of them also have a lot of mitochondria, whose sole purpose in life is to crank out ATP. And muscle cells also have their own version of an endoplasmic reticulum, the cell's transport and storage system, but in this case it's specialized, so it gets a special name, the sarcoplasmic reticulum. Its walls are loaded with calcium pumps, which use ATP to save up a bunch of calcium ions. And it's also studded with calcium channels that are linked to voltage-sensitive proteins in the membrane of the muscle cell. Say I want to move my arm. My brain sends an action potential along the motor neuron until it synapses with a muscle cell in my arm. The receptors on that muscle cell are ligand-gated sodium channels. So when the motor neuron releases our old friend acetylcholine into the synapse, the channels open up and create a rush of sodium into the cell as a graded potential, which if it's strong enough, causes nearby voltage-gated sodium channels to open. Now, I want to take a second to point out here that we're still talking about an action potential, but not in a neuron. This is happening in a muscle cell, people. So that action potential zips along a muscle cell's membrane, the sarcolemma, which has lots of tubes that run deep inside the cell called T-tubules. When the action potential travels down one of those tubes, it eventually triggers the voltage-sensitive proteins that are linked to those calcium channels in the cell's sarcoplasmic reticulum. When those channels are thrown open, the calcium stored inside rushes into the rest of the cell, and finally myosin is like, yeah, here we go. At this point, the myosin is totally stoked, because the bodyguards that had been frustrating it are in for a big, irresistible distraction. That's because the protein troponin just loves to bind with calcium. Remember, when stuff binds to proteins, the proteins change state. So the calcium latches onto the troponin and causes it to pull the other bodyguard protein, the tropomyosin, away from the sites on the actin strands that the myosin really wants to get its paws on. And suddenly it's all, okay? The only myosin heads that can bind to those newly exposed sites are the ones that are ready for action. That is, the ones that have already grabbed a molecule of ATP that's been floating around and broken it down into ADP and the leftover phosphate. When a myosin head does that, it moves into an extended position, kind of like a stretched spring, still holding on to the ADP and the phosphate and still storing the energy that was released when they were broken apart. So after all that, when the myosin primed for action and the bodyguard's out of the way, the myosin finally binds to actin, and it is beautiful. When they bind, the myosin releases all that stored energy, and in the excitement of it all, the myosin changes shape. It pulls on its precious actin strand, kind of like pulling a rope hand over fist. In the process, it shrinks the whole sarcomere and contracts the muscle. That's the sliding part of the sliding filament model. Now, with its energy spent, that little head has no use for the ADP and the phosphate, so they unbind with it because, remember rule number 2, changing shape encourages proteins to bind or unbind stuff. That unbinding causes a small change in its shape, which lets a fresh ATP bind there in its place. That binding causes another shape change, but this time it causes the myosin to release from the actin in a tear-jerking scene like some microscopic recreation of the finale from Titanic. But fear not, this epic is not quite over, because this is when the myosin breaks down its new molecule of ATP into ADP and a phosphate, which moves it into the armed position yet again, getting it ready for its next rendezvous. And meanwhile, those calcium pumps are working hard to restock the calcium in the sarcoplasmic reticulum, so they start grabbing the calcium that's floating around, causing calcium to unbind from the troponin. When it unbinds, the resulting shape change puts the tropomyosin bodyguards back into place. It's a circle, or potentially a big Hollywood franchise with lots and lots of sequels. It keeps repeating itself many, many times every moment while I sit here and talk, and while you sit there and eat and text and take notes, the whole drama replaying itself over and over. Kind of like you'll have to play this video over and over again to get all the little steps of the sliding filament model straightened out. But hey, some stories get better the more you hear them. If you do watch this one again, you will relearn that your smooth cardiac and skeletal muscles create movement by contracting and releasing in a process called the sliding filament model. You'd also relearn that your skeletal muscles are constructed like a rope, made of bundles of protein fibers, and that the smallest strands are your actin and myosin myofilaments. It's their use of calcium and ATP that causes the binding and unbinding that makes sarcomeres contract, relax.
Okay. That was basically our anatomy. Sorry. So that was anatomy and physiology in 10 minutes. I'm sure the first time you hear it, it's going to go, a little too much to take, and even I'm not sure because if it was able to play properly, a network issue. It's a YouTube video. I will be sharing the link. Please watch it because it is very, very good. You can get a good refresher in those 10 minutes, right? Because we need to understand what a trigger point is. So that is the reason why we are doing a refresher on all this. Okay. So, yes, somebody's on the mic. Is there any doubt?
Actually, I want to say that, sir, hello.
Yes.
I want to say that the accent was not proper, according to, and the connectivity was not too good.
Okay.
That's why.
Yeah. So, doctor, what we're doing is I will be sharing the YouTube link of this video. Okay, so you can go and you can see it again.
Okay. Okay.
So because network problem and videos, it's always a problem. But you can always, I'll be sharing the link, right? But I'm just taking you through this because we need to understand the importance of
The
all that.
basics
And
actually.
yeah, exactly. So that video is more than enough for us to understand the basic of anatomy, or to refresh on the basic of anatomy and physiology. But you'll have to hear it, a couple of times, because we've actually left all this long time back, right? We would have
Right.
learned in first year, but
You are,
don't
you are
worry.
right, sir.
Yeah, yeah. So just try to get that animation in your mind about how that the nerve impulse travels through a muscle fiber and how it contracts, right? That is the only thing that you have to understand in that video. Okay. And the next important thing that we need to understand when we understand trigger point therapy is a refresher again on the three types of, when you talk about movement in a joint, and how the movement of a specific joint is by the involvement of a group of muscle. We need to understand, and we need to give more importance to the concept of agonist, antagonist, and synergist, right? I'm sure we learned it. It was probably like a 5 mark, 10 mark question. Again, something what we don't really, keep in mind. But when we talk about musculoskeletal conditions, this is very important, right? What are agonists? Agonists are the main muscle that does the function. What is a synergist? Antagonist. The antagonist is the opposite muscle, and the synergist is what it supports. So, very common example, when we do biceps, right? I do elbow flexion. This is the elbow flexion, and for me to flex my elbow, the most important muscle that flexes my elbow is the biceps. The biceps is the agonist. And what happens is the antagonist, right, is the triceps, and the synergist, the brachialis, etc., acts as the synergist group. So what happens is, when we contract a muscle, right, the agonist muscle contracts, but at the same time the antagonist muscle actually relaxes. That is something that we need to understand when we're doing musculoskeletal conditions, because people are going to come to us with range of motion difficulty. So when their particular range of motion is affected, right, when they say they're not able to flex their elbow, they're not able to lift their hand. So people like this, they come to us, like, they find it very, so it's like this. So they find it very difficult to lift their hand till here, but once the hand reaches this part, they're able to lift, right? Or the other case is they can easily lift till the shoulder level, but beyond this point, they're not able to lift, right? And people are able to move it forward, but beyond this they're not able to. Or it's very painful, or suddenly they say, like, just starting it is very painful, but after that it is okay. Now these are the different set of muscles when it is affected. These people come with different complaints. Now most of the time we do, like, for nerves assessment, like, that is what we do. But we need to understand that even when the range of motion is restricted, when people are coming with pain, we need to understand which muscle is in fact, which muscle is affected. What are the groups there. We need to try the which range of motion is affected. We need to try to analyze which is the agonist, antagonist muscle there,